we're looking at each other, and this is such an important part of our social interaction. And how do we as ophthalmologists play an important role in our patients rehabbing back into their society role? I mean, probably my most proudest part of my career is our fellowship. We train 3 fellows every year. It's a fairly rigorous fellowship. We have glaucoma and complex surgery together in one fellowship for 1 or 2 years. I feel very proud for that because I'm Indian background, right?
That's
so for me, this is...
You are of Indian background and you've been, made waves in the US and Canada and all over the world for that matter. So we feel very proud. Welcome. Today I'm with Ike Ahmed, the famous cataract surgeon, and he's visiting India. And I'm Gaurav Luthra, and we are going to talk on the occasion of the IIRSI meeting here in Chennai at the ITC hotel. So welcome, Ike. And,
thank you, Gaurav.
Happy to have you in India.
Thank you.
We've always been following you, and you've been part of my course. But today is a special day. We want to discuss a few of the things that you are passionate about in ophthalmology. So I thought, I was going to ask you what all are you going to be speaking during this meeting today?
Yeah, no, thank you for having me here. And of course, we work together so much. Love to teach and educate and share. You've been like this as well, and you've been a brother in education. So I love being with you here. And yeah, this meeting has been it's such an important meeting. It's an important meeting for India. You brought so many people here globally. And what I'm sharing here at the meeting are a couple of things. I mean, I of course have a passion for complex surgery. So one of my passions is really repairing the traumatized and damaged iris. So not only talking about the visual rehabilitation and the functional rehabilitation, but also the cosmesis of the eye. We're looking at each other, and this is such an important part of our social interaction. And how do we as ophthalmologists play an important role in our patients rehabbing back into their society role? And part of that is making sure their eye looks normal and the way they're looking at the world is intact as much as possible. So that's one of my talks as well. I'm a big fan, of course, of dealing with IOL, complications as you are as well. So talking about different ways to fixate IOLs, whether it's to the sclera, to the iris, the anterior chamber, the pros and cons of each approach should be individualized for the individual patient and also for the individual surgeon. What is their comfort zone with? So I'll be talking a bit about my approach to doing this. We teach many of our fellows these options as well. And then also dealing with more complicated cataract issues, dislocated cataracts, one of our favorite things.
I see all those amazing videos, and you're left spellbound. And so, which is your favorite IOL fixation technique? Like, given a choice, if you had an eye which could do all of them, like which one would you pick? What do you feel most? What do you think is the most elegant and the most thing which suits the eye?
It's so hard because I have to say I do customize. I mean, I have to say if I have given one choice, the intrascleral haptic fixation, whether it's Yamani or double needle or glued, some form of haptic fixation in sclera, has been really beautiful for us. And I find the lenses are well positioned, well centered, refractively the results are fantastic, recovery. I like this a lot. Of course, for me, I do like to make sure I do a good vitrectomy, a good posterior segment, approach for that purpose. I have to say, I unlike many people, I do have a lot of success using iris suture fixation, especially if you don't need to do a big vitrectomy, because there's less manipulation in the posterior segment. It does take some technical, nuances to do that. Those are my 2 most common approaches. And of course, I have to be honest with you, for some very older patients who have good corneas, an old-fashioned ACLO may be appropriate for some people as well, So that's kind of my approaches. I don't know what you think, but
I totally agree, because each patient deserves what his eye deserves. I mean, what suits best. As you said, customize it to each patient, and that's exactly what I would think so too. I would love to be able to do all of them, and I keep learning all the new techniques.
Yeah.
And going on, I think I love your iris reconstruction videos, and the especially one which I haven't seen here, but I saw it in the SCRS where you've implanted that human optics, so the iris which almost looks as good as the other one. It's beautiful. It's very time consuming, and I think you have a passion for iris repair. And then the third thing which I always appreciate about is that you've been a big proponent of early intervention in glaucoma, and I keep following you for how you are going forward in that direction. So what are your thoughts? Because in India we haven't really caught on with the traditional trabeculectomy, and medical management is what has it. SLT never became popular in India for some reason. There were a few studies done, and then after that the devices were probably too expensive to begin with, but now people are beginning to accept them, but they are still minuscule fraction of people are still doing it. So, and we all are very interested. So I'm not talking about any one procedure, but like, what are your thoughts about why should we be, if at all, intervening early in glaucoma?
I think it's a great question, and I think this field of interventional glaucoma is growing. We started, in some pockets in Canada, United States, and now it's going to Europe a bit more. So I think glaucoma has really undergone a lot of changes. I mean, I think we understand the medications have a role, but the challenges with compliance, adherence, quality of life, and then the limitation of effectiveness, limit their ability. Surgery, as trabeculectomy is very effective, and we do use it, but, the morbidity and the challenges make it something we leave for the end, So there's a big gap, right now in terms of the ability to do something for patients in between these options. And interventional glaucoma really is not about even a technology, it's about a mindset, thinking about, should I be intervening for this patient at the right stage of their disease? Now, we're still figuring this out, but the idea is, for example, you mentioned SLT laser. The evidence is very strong, for example, to use SLT laser first line. We address compliance, adherence issues, and the pressures are better controlled, but not only that, progression is less, and the need to go into major surgery is less. So the evidence is very strong for this, We look at now the opportunity to do something with cataract, So many of our patients have cataract and glaucoma. It's like a one-time opportunity to do something together, and if you do it in a way that is safe, then it works well with cataract surgery. And now we have many MIGS devices, MIGS options now. And yes, there certainly are reasonable questions around cost and value, but I like to look at the example of IOLs and phaco. Yeah. There was a time I think we all would argue and say, like, extra cap is cheaper, or even patients say phakic may be something as an option. But as things became more universal, we have different innovative ways to find coverage. I think you'll find this as well as MIGS, yes. But there's a demand. There's a demand, I think, even in India for the ability to address medications in a better way. And, we know medications have a lot of limitations. Even in India, compliance is poor. And if our goal in glaucoma is to prevent progression, then we should be proactive about it. And I think safety is showing there. So I'm excited to see what's happening in India. You're a leader here as well. And my goal is that glaucoma treatment should be democratized, not just for a glaucoma specialist who will do maybe trabeculectomy, but you see glaucoma patients all the time in your clinic, right? All the time.
Coexist so often, yes.
Absolutely. And so you're a fantastic cataract surgeon. You apply the same skills to glaucoma in a way that synergizes well with cataract surgery. It's a great entry point for this one. You see patients who are coming to you for follow-up. They're doing their drops. We find out, they need to do further than that. What about laser options, So I think that's kind of what our idea is. It's going to be a big challenge because obviously operationally it means changing our mindset, changing our practices, changing our OR. It's not easy to do those things, but I think we're seeing this changing. And I think there's also going to be an issue about how do we value and the cost and everything else. And that's why there's various options. We customize it for the patient, And I think that's where we see interventional glaucoma going. We see the same thing with phaco, right? Phaco took a while to become adopted. Refractive surgery changed with the benefit of LASIK, for example, retinal surgery, corneal surgery, and now finally glaucoma surgery. We're seeing this. So my advice would be that, it's worth at least, my colleagues in India to look at this seriously because the wave is coming. Right. And those of you that are coming ahead of the wave will be most ready and adapted to be leaders in this field. So get ahead of the game, that's what I say.
So there is huge interest in India, and that's why I wanted to ask you about, there are like several procedures available now, and in India we are kind of doing all of them, just like in the early stages. So for immediate and for maybe the medium and the long-term success, which are the procedures? How would you decide, like, since you do all of them, how do you decide which patient would do better with one or the other?
Well, I think if we talk about the context of disease severity, obviously you can easily segment out patients with advanced refractory disease. Those patients need to have blebs, and so we have to understand MIGS will not suit those patients, so we put those aside. But most of our patients we see are not advanced. They're typically earlier, mild to moderate. There may be one or two medications, and that's where I think the context is important. So combined cataract surgery, we need a procedure that works very well. If the recovery is longer, patients are unhappy, you're unhappy. If the post-operative course is up and down, it makes the recovery. So we want a procedure that's going to work really well with cataract surgery, which is really a fantastic procedure, as we know. I think that's where we've seen the evidence with stenting to be really second to none. Safety-wise, recovery-wise, it's really minimal difference to cataract surgery. And so I think that's, for me, melds the best with regards to cataract surgery in terms of the ability to recover like we do for cataract surgery. Now, there's a learning curve with this, of course, placement of stents, and to be frank with you, there's also a cost. That's where we have to look at the value on that. Other options which are not involving implants, like cutting procedures, stripping procedures, they have a role too, especially when there's access issues, I think that's where we have to look at the patient, the context, and everything else. But there's no doubt, combining with cataract surgery, we see stenting to be a really good combination. That's kind of the way I look at it. But, there's a role for all these options, and I think it depends on the context and the physician and their practices.
So I have put in a few now, and we've seen. I mean, it's too early for me to tell you whether I feel that it's working miracles. But you've been doing this for maybe 5, 6, or 10 years. I don't know, and you've gone through the evolution of these stents. Do you see long-term success? Like, how many years does typically the benefit last, and what percentage of patients will continue to see fairly good control and not require another procedure, a surgical procedure, in the future?
I mean, the one thing to talk about in glaucoma is that we're always, chasing the disease, So anything we do, we know is not necessarily going to be a long-term fix. But if we can keep things prolonged for a longer period of time, this benefits the patient. We have now 15 plus years of experience personally with these procedures, and we have our follow-up data. Of course, it's hard to study the long-term data, but what we see is we have a reasonable durability of these procedures. After all, the disease pathology is an intraretinal meshwork. If we can permanently bypass this and control healing, we should theoretically at least have a good control, as long as the patient doesn't progress further with their downstream disease. So our results so far have been quite good as far as long-term benefit. Most importantly, the safety part of it we have to establish. Without safety, we cannot even think about doing the procedures. And safety-wise, I think we have really no concern about this long-term safety with the cornea, with the tolerability in the eye. I think that's what we're seeing, And anything that we know that can prolong the need to go on to major surgery is a benefit. This is what we're seeing in mixed procedures, like, for example, stenting procedures. Anything that delays progression is a benefit. Because we know that glaucoma is always going to be a threat. And if we delay for 2, 3, 4, 5, 10 years, this is a benefit for our patients. I think we at least can feel confident in doing that.
So if a cataract surgeon, this is like, my last question to you. If a cataract surgeon wants to transition into adding a mixed thing, and in India we only have the eye stent available to us.
Yeah.
So what should he start doing first? Like, before he does his first implant, can you just tell it for the benefit of some of those surgeons who are now beginning to think that they want to do this?
Well, I think, it still behooves us to be, a real, appropriate glaucoma assessor. So we need to make sure we have good diagnostics, good, OCT visual fields. Gonioscopy is critical. Right, so I mean, this is an area where a lot of us are weak on, but in the office, getting good views of the angle, understanding gonioscopy is important. Really, the secret, as you probably know, is visualization. If we get good visualization, good positioning of the patient, good positioning of the microscope, then we can really perform the procedure like the stenting procedures we talked about, very predictable, very controlled. That's why I think most of the work has to be in terms of setting things up. I recommend, when you're doing routine cataract surgery, even without doing mixed procedures, end of the case, just tilt the microscope, do it manually, tilt the patient's head, put a lens on the eye, get a view, even put a cannula, look around a bit, and just get comfortable doing this repeatedly. Because that's really the hardest part, Are you pushing on the cornea too much? Is the viscoelastic in the eye of sufficient volume to keep the pressure in the eye? Are you pushing on the wound, Once we work on that part of it, I think technically then moving to actually doing the procedure becomes shortened. The learning curve becomes shortened. Obviously, there's still going to be a learning curve. I think that's the best, the setup, and the visualization is most important. And just being comfortable with glaucoma follow-up is obviously key.
Perfect. And I remember that you have passion for teaching fellows in complex cataract surgeries as well. So do you have a fellowship program which people from India could benefit from? Like, if somebody wants to apply, can they apply directly to your institute? And what kind of fellowships do you offer at your place?
Yeah, I mean, probably my most proudest part of my career is our fellowship. We train 3 fellows every year. It's a fairly rigorous fellowship. We have glaucoma and complex surgery together in one fellowship for 1 or 2 years. We've had international fellows around the world. We don't have anybody yet who's actually from India who's come to train with us. I have one of my fellows who's from the UK, and she's working in India now. So we definitely are always open to international graduates. And in Canada, which is where my fellowship is based, we have very good processes for that. I also work in Utah as well. I have fellows there as well. That program is more geared toward U.S. Graduates, but our Canadian program is quite international in that. And so we encourage people to visit us, of course, at least, and come and see what we're doing, and we hopefully have one of our first trained Indian fellows in the future, hopefully.
So I think anybody who's really keen to go must go visit Ike Center to see some amazing work. And thank you so much for sparing time, Ike, today. And it's been a privilege to host you in India and also to be able to talk to you like this in spite of your really busy schedule. Thank you so much.
No, thank you so much. I want to say, listen, I mean, I'm proud of the work that you and many of your Indian colleagues have done to innovate, to teach the world, to spread the knowledge, because India is a force. You go to the meetings in the United States and Europe, you see the instructors, you see the abstract presenters, and India is probably even overrepresented. And this is something that you've been doing for 20 years, you know, and you've led the way to teach and share the Indian way of thinking, which is innovation, which is making use of whatever resources you have in your environment to do the best results. So, I mean, and I feel very proud for that, because I'm Indian background, right?
That's
so
what I was going to say. You are of Indian background, and you've been, made waves in the US and Canada and all over the world for that matter. So we feel very proud. And today, amongst all our faculty, we saw some of the brilliant people of Indian origin who are, kind of doing so well in the US and all over the world actually. So we take a lot of pride in what you are doing.
Amazing.
So it's amazing too. Thank you so much, Ike, and it's been great to have you. I wish you a wonderful rest of your trip in India, and we hope to keep seeing you every year for some meeting. That would be amazing.
I hope so. Thank you very much. Thank you. Thank you.